Welcome. My name is Dr. Gordy Schiff. I work at Brigham and also I'm the Quality and Safety Director of the Harvard Medical School Center for Primary Care. I want to talk to you today about what actually turns out to be the #1 cause of medical errors, and we'll explain a little bit why I assert that. Let me just start with financial conflicts, which I have none in terms of commercial. The Gordon and Betty Moore Foundation and CRICO HRQ funded a lot of this work. So what we'll be covering today is, first of all, giving you some just general background on diagnostic errors. This has actually become a very interesting new subject, even though each of us are familiar with problems in diagnosis and making mistakes probably from day one of medical school, but the, the new data and frequency, I'll give you a couple of studies talking about cognitive errors. That's probably the kind of thing you might find on the board tests more likely, so we're going to cover that. And then we're going to really talk about thinking about diagnosis really as a system and looking at some of the recommendations from the National Academy of Medicine report and some of my own practical suggestions that derive from that. So as I mentioned, the National Academy of Medicine, now it's 5 years, came up with this really, I would say, landmark report that shined a spotlight on the need for understanding that diagnosis was part of patient safety. There was a time when we were looking at medication errors or wrong site surgery. Very little work was being done in this area, but this is now especially catapulted by this report, been displayed more prominently. And what they emphasize and what we all know is diagnosis needs to be accurate, it needs to be timely. And the thing that they added here especially is it needs to be well communicated to the patient. And so let me give you, we're in Massachusetts from where I'm speaking now. They did a survey, Betsy Lehman Center, who we work with closely, a patient safety organization affiliated with the state of Massachusetts. They asked people whether they had been personally or someone close to them had been involved in a medical error, and you can see 1 out of 4 said yes. And here's the interesting thing, which is, I think, a revelation at this time. #1 was diagnosis. You or your medical problem was misdiagnosis. This is ahead of surgery or mistreatment or incorrect medication. Another study was done by the Institute for Healthcare Improvement, the National Safety Foundation, asking a little broader question: if you had experience with a medical error, either you personally or someone you knew. And here you get, rather than a quarter, you get 40%. So almost half the people, either themselves or someone else, and you can see how it breaks down on the right-hand side here. But again, here, what's #1? Misdiagnosis. In fact, #1 and #3, the diagnosis didn't make sense, or there was a misdiagnosis, treatment mistakes, etc. So again, misdiagnosis, leading type of error. And then these are just some very general harvesting of a variety of studies, malpractice cases, and we're going to look at those in a second. Diagnostic error is the most frequent allegation. Internist misdiagnosed 13% of patients. When you had standardized patients, somebody with rheumatoid arthritis or COPD, they sent them to different doctors, sort of secret shoppers. 13% of people miss those. Chart reviews, 5% of chart reviews show a diagnostic error. Autopsies, which, as we all know, are much less frequent, but even in this era, 10 to 20% find significant major unexpected findings. Radiology, pathology, you can see some error rates here. Those are easy to measure in radiology pathology. You just have someone reread an X-ray or a path slide and finds that you can miss clearly in 2 to 5% of the cases. So this was a study we did a few years ago in Massachusetts. We collected all the closed claims of malpractice cases. We were interested in primary care cases, and there were roughly 100 a year. And it turned out of those 500, 400 out of those 500 over the 5-year period were diagnosis related. Again, it beat medication. Not only was it higher, it was just by a factor of 6 to 1. And again, here we're talking about primary care, internal medicine, where many of you are practicing. This is what's happening. What kind of diagnoses are going to be missed? Again, no surprise, cancer, leading leading the pack ahead of heart disease and infectious disease, orthopedic injuries. So cancers, we talk about the big four: colorectal, lung, prostate, and breast, really were the lion's share of these misdiagnoses claimed and for which patients sued and often won. So this slide breaks down those closed claim malpractice cases, and it really points out something very important and interesting that we found in doing this study. If you look at all the non-general medicine and non-diagnosis cases, really about 70% of them are either settled or dropped or dismissed. People talk about doctors losing in court, but only 1% of all claims are lost in court. And again, 20%, there's a settlement. Let's jump over to these diagnostic error cases. Twice as many, 39% versus 40% versus 20%, are either dropped, are settled. What that means, again, in very oversimplified terms, is the malpractice lawyers who are defending these cases look at the chart and they said, oops, I don't think we can defend this case. There's an X-ray lesion. The doctor was told about it. They didn't follow up, high PSA, et cetera. So these imply to me, again, they're not thinking about malpractice, these imply to me that these are opportunities for improvement. Twice as much preventable error types are found in these kind of cases. And even the ones that go to court, 2% are won. So there's definitely, certainly room for improvement, and that's what we're going to be talking about here. This is another malpractice carrier that we used their cases, but they looked through the top management claims categories of their claims, and they had something called clinical judgment that comprised a lion's share. You can see some of these other issues, communication, documentation, et cetera. And what do they mean by clinical judgment? And we're going to delve into this a little more ourselves here. Narrow diagnostic focus, inadequate testing, misinterpretation of diagnostic studies, failure to address the patient's clinical condition, appreciating how sick they are, failure to obtain outside records or consultation referrals. We also did a look at a lot of cases. We have a very large case series where we reported, and again, failure to consider a diagnosis is high on the list. So here we are in this sort of cognitive realm, which I'm going to spend relatively less time on than some of the system factors. But I think all of you need to be familiar with this short list here, and the next slide is a little longer one, of common, we'll call heuristics or biases. These are things that we as humans are sort of hardwired to make these kind of mistakes, something called availability bias. So you just saw someone die of a subarachnoid hemorrhage, so you think the next person who has a headache is going to have a subarachnoid hemorrhage. Really, you're not fully appreciating the incidence of this being relatively rare, et cetera. Anchoring. Somebody's admitted from the emergency room. They have a diagnosis of pneumonia. So you stick on that with that diagnosis, even though it turns out it might have been PE, and you failed to reconsider the diagnosis. Confirmation bias. You have a hunch. You think somebody has a certain problem, and so you do testing to confirm or prove what you already believe, often to the exclusion of not considering other things. Search satisfying. Once you find what you believe or you want to confirm, you stop looking, and that's, again, very frequently seen in these cognitive errors. Hindsight bias, I'll just do one more from this slide, and this is a real problem with diagnostic errors. You know, when you look back, it's obvious all along that this was a brain tumor. They didn't listen to the patient, and the signs were all there. Well, we all know what it's like to have somebody come in with headaches in our clinic or non-specific things. So we often get blamed for things that look like no one should have missed, but this is a bias when you look backwards. And again, here's a taxonomy that we're actually using on cases currently. Again, most of the same elements. I would mention number 8, that we added a demographic stereotype bias. There's good literature now that, you know, if a woman comes in with chest pain, she's less likely to have the correct diagnosis. Patients with minority groups complaining of pain, somebody thinks they're drug seeking. These are prejudices we really have to recognize and overcome. So what is a diagnosis error? The Institute of Medicine has a definition that we just talked about related to timely and accurate and communicating to the patients. But I think there's another way of looking at it, and this is one that I find most helpful, is really trying to differentiate getting the wrong diagnosis, misdiagnosis, from diagnostic process failure. So somebody's, sample in bed A and bed B of the hospital are switched. So the sodium comes back 122 on patient in bed B when really they've had a normal sodium. It was the other patient's blood sample. Really no harm. You're not making a diagnosis of SIADH or doing anything or adverse outcomes. But what about Linda McDougall? And again, I'm not violating confidentiality. She's on the cover of Newsweek a decade or so ago. She had woke up from her breast cancer mastectomy, and the surgeon said, "You don't have breast cancer." And she said, "I'm glad, doctor, you got it all out." And after this bilateral mastectomy, the doctor said, "No, you never had breast cancer. Your past specimens was switched with another patient." So she obviously had a misdiagnosis and an adverse outcome as a result of that. Again, we obviously really focused on this. Somewhere between 40 and 80,000 patients a year are said to be dying in hospitals as a result of diagnostic errors. So this little slice has some big implications in terms of numbers and adverse outcomes. So what are we going to do about this? The National Academy of Medicine has these 8 goals, and I'll just put them up here from their report. And then we're going to talk about some of them that I think are the key ones that we want to impress and explain better to you. Number 1, more effective teamwork. So this idea that the pathologist and the radiologist and nurses and the patients themselves are really part of making the diagnosis, and we really need to leverage that better. Talk about that some more. Enhancing professional education so that, just like we just taught you about the kind of mistakes, the cognitive biases that are happening and the awareness you need, there needs to be more training about this in medical school and CME. Number 3 is ensure that health information technology support patients. And we're going to talk more about that, but I think everybody in the audience, I gave this talk live last year, and I was literally flooded with, including one clinician with tears in her eyes, that the electronic record is just doing us in, and we can't think about diagnosis. It's so frustrating and time consuming, user unfriendly. Develop, and so we're going to overcome that and actually use this in a positive way. We'll talk about that. Develop approaches to learn from and reduce errors. So we should be sharing errors. Again, I mentioned we have this project with Betsy Lehman Center. Every month we get together, we talk about cases across institutions. We need to make it safe to do that. We need a work culture that supports improvements, at the very least, that has enough time for us to see patients, et cetera. Developing reporting and medical liability systems. So when these cases happen, we all don't have to make the same mistakes. We can learn and share them. Redesign the payment system. Again, partly that means having enough time to see patients. We're obviously in a time of COVID where the whole ways that we're caring for patients has been upended, and we're going to have to figure out. I'm not doing physical exams on my patients that I'm mostly pretty much seeing virtually. So this is all from 5 years ago, but we really need to think that through. And then there needs to be money to do research. There's only a tiny amount of dedicated funding, and that needs to be improved. So I would boil this down, and we'll second half of this half hour, 5 practical suggestions. Number 1, we do need to develop this, what we call culture of diagnostic safety. This sort of sounds like it's sort of a touchy-feely thing that we can't really get put as a right or wrong answer on a board question, but as I'm going to show you, I think it's really important, and the data also supports that. We should learn from each other. We should anticipate the errors that we know have happened. We need closed loop systems where we don't have drop balls in terms of tests and symptoms. Talk a little bit about that. Health IT, and then finally, how are we going to gauge the patients better? So let's just talk about the culture of diagnosis safety. We wrote this up in an editorial recently. Number 1, driving out fear. So no one's afraid to ask questions. So when something goes wrong, the patient should be able to question it. The nurse, the relatives, instead of making this assumption that the doctor knows best and shouldn't be questioned. Questioning is very important and should be no fear. The organization should be committed to diagnosis. Looks like there's overlap here. It's the screen. Uh, Learning from diagnostic delays, leadership of the hospitals, do they really think about diagnosis errors as a number one cause of patient-reported errors, and what are they doing about this? So everybody who's working with patients should be curious about what things we might be missing. We should be obsessing over the details of the diagnostic process, all the process that we return lab tests and make sure referrals happen, and think about all the things that go wrong. Number three is recognizing that uncertainty is inherent. So all the tests that we order, there's false positive, false negatives. There's a need to have safety nets as a result of this uncertainty. We also need conservative approaches because we can't be ordering head to toe CTs and MRIs on every patient. It would probably definitely be doing more harm than good. So we need to think about that. We need to respect human limitations. So we should be not relying on human memory to call somebody back or follow up, or even remembering what I learned in medical school about the causes of hematuria. Again, talking about what's going on with multitasking and distractions. The EMR has to be redesigned to support cognition, and then an enhanced role to the patient. So this idea about the doctor is the producer and the patient is the consumer really needs to be reformulated, that diagnosis is co-produced by patients. We'll show you another slide about that. Number two is learning from and sharing errors. We have this concept called diagnostic pitfalls. I'll show you some of our data. So diagnostic risk, situational awareness, or thinking about what went wrong. So there's these studies of what we call high reliability organization, nuclear submarines and the ships in the Navy that, people have very high risk and high potential risk, but low frequency of risk because people are worrying about what can go wrong. People are preoccupied by risk, thinking about what could happen. The Sullenberger, who landed the plane in the Hudson River, was one of these people who was high reliability, worrying about things. There'd never been a water landing of a domestic air flight, but before they took off that day, they had rehearsed what to do in that case. He saved everybody on that plane. As a result, people might have seen the movie. Appreciation of diagnosis, uncertainty and limitations. So knowing which tests have false negatives, and also knowing when you're over your head and when you need to help, making failures visible. And then there's this concept of don't miss diagnoses and red flags. We'll talk a little more, in diagnostic pitfalls as a useful construct. So what do we mean by don't miss diagnoses? I call this the 4 R's: rare, rapidly progressive, remediable, and really bad. So something like spinal cord compression. How many of our patients have back pain? I had back pain this morning. But of the people with back pain, only a very tiny percentage have cord compression. But if you miss it in 24 hours, that person's going to be paralyzed. Upper airway restriction, pericardial tamponade. So these are things you want to take and put high on your list to consider and have a worry about these, that you might be missing these, thinking about whether there's anything to suggest these. And then I use the 4 C's: continuing exposure, contagious, chronically progressive, or confusing. I guess we would put COVID up here as a very prominent example. You'd hate to send somebody back home with COVID infection to a workplace or a big family and not recognize that, or carbon monoxide poisoning, back to the space heater that's emitting, leaking carbon monoxide, or TB, just like the COVID example, or occupational asthma. So these are things that you really hate to miss, to just say, we'll give you your asthma spray and just go back to the job you're doing without recognizing they're going to be continually exposed and worse, pulmonary fibrosis, whatever. This is a list we're writing a textbook chapter on this for Harrison's. We're excited this has reached that recognition. Again, I'm only going to flash this list. You can refer back to it. But, things such as tension pneumothorax, or peritonsillar abscess, or necrotizing fasciitis, temporal arteritis. I think we know the kinds of things we need to really, and this list isn't huge. There's only a couple of dozen, maybe 3 dozen things here, celiac scro, that really are highly treatable or rapidly progressive. We can really make a difference. So we want to keep these high on our list. What is a diagnostic pitfall? This is a situation where there's patterns or vulnerabilities that can lead to error. So these are sort of accidents waiting to happen or things that we should be aware of. So we just did a study where we looked at hundreds of malpractice cases, and these are the kind of generic things. Disease A, repeatedly mistaken for disease B. So bipolar disease, miscalled as depression. Failure to appreciate the test limitation. A breast lump, woman gets a mammogram, it's normal, and said don't have to worry about breast cancer. Of course, that test requires further workup. Atypical presentation. Presuming a chronic disease accounts for a new symptom. So lung cancer is somebody who has pre-existing pulmonary symptoms, or maybe you have a swollen leg, knee, and somebody who has rheumatoid arthritis, and you assume it's the RA and that you're going to miss septic knee. Overlooking drug and environmental causes, failure to monitoring evolving symptoms. So things change over time, you don't monitor people. So we have sort of this model, and again, how we translate that, or is that really, I think, we look to you to think that, but you have, on one hand, you have red flag symptoms, you have don't miss diagnosis, and then you have known pitfalls of things that go wrong. So we like to think this is a situational awareness model, and you need to develop your skills to have an awareness, or even the computer should be reminding us of some of these things. Closed loop systems. So medicine is an open loop system. It's like the water goes on the same time every day, regardless of whether the lawn is flooded or it's raining out. We don't get feedback on our diagnoses. And we did this trial where we called patients after they went home from urgent care visits in 3 clinics in Alabama. And 16% of the patients had not improved, and most of those patients had not followed up or contacted the clinician. We think this is key in patient safety because, you know, it conveys to the patient our uncertainty and their need for them to be involved in following up. It allows us to have a differential diagnosis. It makes invisible diagnoses visible when we do find out we miss things. I'm going a little quickly here, but health IT, I don't want to shortchange because we've been for over a decade trying to think about ways clinical documentation can help prevent diagnostic errors. You know, we tend to think of clinical documentation as the paperwork to do after the job is done. Obviously, we're not talking about paper, but this idea about we're just CYA for malpractice or billing, but we really need to turn the CYA into a canvas for your assessment. What do we mean by that? It's using the time when you're writing these charts, not to check boxes or satisfy some third party, but just to be thinking out loud, your differential diagnosis. How likely are they? How certain are you? What's causing these? How urgent is this? These are the kind of things that we should, again, be interacting with the computer. The computer should be even helping us generate some of these differential diagnosis and even likelihoods. And we should get the narrative to use the narrative to think out loud and let other people see our thinking. We have a series of things that we have collated about how health information technology can actually help reduce diagnostic error. And again, I'm going to be very quick in reviewing this list, but there's tools that can assist in information gathering. We're seeing some of that come to the fore even in COVID, where patients are filling out questionnaires ahead online. Differential diagnosis generators, calculating Bayes' theorem, weighing the prior probability, posterior probability, tools to make sure patients get followed up and we can track them, alert us when screening tests are due. Colonoscopy needs to be repeated in 3 years, so this can help us hardwire that. Getting specialists instantly, we should push a button. Here's a rash, what do you think? What do we need to do? And then getting feedback on our own diagnostic performance. And then finally, working with patients. As I mentioned, this idea about co-producing diagnosis. And what are the kinds of things that we look to patients to help us do? Number one, they need to first obviously access us. So if somebody's sitting there with a mass growing in their neck, if they never come in, if they never are high fever or they're very sick, then we're not going to be able to make a timely diagnosis. They need to help us with continuity and follow-up. Check your fever for the next 24 hours. Call in 24 hours. Tell her how you're doing. Proactive on test results. If you haven't heard back from me about these results in a week, get in touch with us. We tell people about all tests, normal and abnormal. Sharing your hunches. Sometimes patients come in with crazy ideas from the internet, but often that's helpful. Boy, I never thought of that. Let's consider it, or at least we know what's on the patient's mind. Active as a co-investigator, being patient with time and tests, grappling with uncertainty, respecting the limits on our time and staff, agreeing to disagree. I have a patient who's convinced she has lupus every time I see her. There's no evidence at all, but we just agree to disagree, but we're kind of clear in communicating that. Getting involved with patient organizations. As I mentioned, we have a diagnosis community now that's been growing, Diagnostic Errors, and we have hundreds of patients come to these annual conferences over the last 10 years. So question is, what will it take to help this flourish? Certainly something with malpractice, guns pointed at our head, where we're not going to feel comfortable being honest and working with patients. That's sort of antithetical, but something where we have really good trust and relationship with our patients. We're going to minimize and prevent diagnostic errors. So to summarize, and again, add some practical ways you can take this into your practice. I sort of distilled 3 questions related to individual patient care. So number one, what else might it be? You're looking at somebody, a patient who either has something that seems straightforward and well explained, or something that you're scratching your head about. So forcing a differential to be made. What doesn't fit? Okay, this looks like sort of a typical case of pneumonia, but why is this person have anemia? Well, that doesn't quite fit with what I expect normally in pneumonia or any other situation where there's a lab or a physical finding that just doesn't really seem to go along with this, and might be a clue that we're missing the diagnosis. What critical diagnoses are not to miss? So we talked about this, don't miss, red flags, known pitfalls. So let's consider pericardial tamponade when somebody comes in with acute heart failure, because we just don't want to miss that, or back pain and spinal epidural abscess. And then I have these 3 questions related to the care systems we work in. Do we have a reliable closed loop system for tracking our results? So when a critical referral, we send somebody to dermatology for a mole that looks suspicious. Do we have a way of making sure that that patient got seen and we get the results back, or a lab test? We're working on a project with Beth Israel clinic now that we're really going to, in Northeast, engineers from Northeastern, because we really need to re-engineer our care systems to make these highly reliable in terms of these drop balls and closing the loop. What's the culture of safety and climate in our clinic? You can actually measure that, and we're actually working with HRQ to develop a new tool specifically to measure diagnosis safety climate. But do people feel comfortable speaking up and questioning? And if something's wrong, do they get blamed? They're just not going to share the mistakes then, or are they supported and use that as an opportunity to learn? And how does the EMR either get in the way of efficient, timely, accurate diagnosis, which I'd say it does more often than not now, versus how can it be improved to really be a part of the solution, a major part of the solution? So those are the 3 care questions. Those are the 3 patient care questions. These are the system questions. Takeaway points: diagnostic errors are the #1 type of medical error and safety problem. This is according to patients, according to malpractice suits, and we need to recognize that. And addressing that means, first of all, thinking about clinical reasoning and the biases and heuristics. These are things that are ubiquitous and we're practicing, and there's some controversy about whether we can do some debiasing things where we create awareness around this to immunize ourselves. And but at least we should all be aware how these things are working. Clinical uncertainty, again, that's also very widespread. We need to be able to acknowledge that. We need to become comfortable with dealing with clinical uncertainty and communicating it to the patients. Doesn't mean we're bad doctors, we're not brilliant diagnosticians. It means we're really being honest and transparent and real, and we're going to create safety nets, especially around the don't miss diagnoses, red flags, things that can go wrong. That's what's going to make diagnosis better in terms of hardwiring some of those things that we can do. We need to leverage and redesign the electronic medical records to support cognition rather than getting in the way. We need to engage our patients working with us to co-produce better diagnosis. And then, as I mentioned, there's 6 key questions to ask yourself: 3 about an individual patient, diagnosis you're considering, and 3, just the systems you work in. I have a quiz question, 2 quiz questions. Which of these is not true? Diagnosis errors are the #1 type of error. There are many types of failures in the diagnostic process. The most don't result in harm. More important than making the exact right diagnosis is safety nets to ensure reliable follow-up. And then finally, making sure that patients do not interfere with clinicians making the correct diagnosis is a good strategy for preventing misdiagnosis. And I guess we pause here. I hope the answer isn't too obvious, but it is obviously the final one. Patients are not interfering or getting in the way. They really need to be front and center in terms of our efforts to engage them and help us make better diagnoses. Which of the following are not ways that electronic medical records can be leveraged to improve diagnosis and decrease errors? First, provide a space to craft your assessment and differential diagnosis, your degree of uncertainty and contingency plans, hardwired delivery and tracking of key test results and referrals, provide comprehensive lengthy notes to document an extensive review of systems, questions that are copied and pasted from preceding visits and others' notes for billing and defensive medicine purposes, facilitate easy access to reference materials so clinicians can more easily look up the information, and aid in calculating the likelihood of various diseases using Bayes' theorem to help suggest probabilities. Again, hopefully this is clearly not the way to go. These notes that are just filled with copy and pasted information, we may think we're fulfilling some mandate for billing, but in fact, it's really getting in the way of good notes and good diagnosis. So in the way of references, there's a wonderful series of webinars. Each one of these is 10 minutes long. If you would like to go through these or use these in your practice to go through it with other folks, highly recommend, brand new in the last few months released. And then finally, some readings that you can consider looking for more information.